So today we will discuss about the male osteoporosis. Why men have a low risk of osteoporosis and fragility fractures as compared to women. Probably because women have bones with smaller diameters, lower peak bone mass, and menopause related bone resorption process, and a higher risk of falls than men. Despite osteoporosis and fragility fractures being less common in men than men, 39% of osteoporotic fractures worldwide occur in men. These are few studies which does show that around 30 to 40% of fractures do occur in men. In both men and women, the incidence of hip fracture increases exponentially with age, although in men, the increase begins approximately 10 years later. These are further few studies from US which does show that the incidence of hip fracture is men ranging from 0.56 per thousand per year at the age of 60 years, and it has increased from 0.56 to 13 per 1000 per year at age of 85 years. Similar results were reported in other studies which had shown that the incidence of fracture per 1000 person years, uh, and this study was done for hip fracture only, so it has increased very much from 0.49 to 12.3 at the age of 85 years, and a 60-year-old man has an approximately 25% risk of having an osteoporotic fracture during his remaining lifetime. Men are less likely than women to be evaluated and receive the anti-resorptive treatment after a hip fracture. Mortality rate associated with hip fractures and vertebral and other fractures is higher in men than in women. Male osteoporosis is underdiagnosed and undertreated, both in primary and secondary prevention of fragility fractures. So after reaching the peak bone mass in the third decade of life in most individuals, men lose approximately 30% of their trabecular bone and 20% of their cortical bone during their remaining lifetime. Epidemiological studies suggest that secondary causes for osteoporosis can be identified in 40 to 60% of men who have osteoporotic fractures. Probably we should try to rule out hypogonadism, glucocorticoid therapy, GI disease, vitamin D deficiency, medication history like anti-seizure medications, hypercalciuria, and alcohol use. Other few studies indicate that levels of bioavailable estradiol rather than testosterone are strongly correlated with the BMD and fracture risk in men. In patients with androgen deprivation therapy, it do have role. Vitamin D deficiency is associated with low BMD, poor physical performance, and increased risk of fractures. These are the few causes of osteoporosis in men, in which endocrine causes are these: hypogonadism, delayed puberty, estrogen deficiency, hypercortisolism, hyperthyroidism, hyperparathyroidism, vitamin D deficiency, growth hormone deficiency, diabetes mellitus. These are the causes. In the connective tissue disease, osteogenesis imperfecta, Ehlers-Danlos syndrome, Marfan syndrome, homocystinuria. Other GI disease are the malabsorption syndrome, inflammatory bowel disease, cirrhosis. Hematological disorders are multiple myeloma, chronic hemolytic anemia, systemic mastocytosis. The history of drugs is also very important, like glucocorticoids, heparin, thyroxine, suppressive therapy, anti-seizure medications, gonadotropin releasing hormone analogs, cyclosporin chemotherapy, HIV medications. Others are eating disorders, immobilization, rheumatoid arthritis, renal disease, cirrhosis, and alcohol and tobacco. So These conditions we have probably already described, and history of it is invariably associated with aging, as we can see that. And other is personal history of fracture as an adult, and low BMI itself is a risk factor. There are very few studies on the diagnosis and treatment of osteoporosis in men as compared to women. In men 50-year-old, osteoporosis is diagnosed either by the presence of a fragility fracture after the age of 50 or by low BMD. In some parts of the world, only hip and spine fractures would lead to the diagnosis of osteoporosis without a T-score of minus 2.5. BMD measured by DEXA of the spine and hip remains the best test to predict the future fracture risk. Other societies like National Osteoporosis Foundation, Endocrine Society, and ISCD recommend BMD screening men at age of 70. Between age 50 and 70, BMD is recommended if risk factors for osteoporosis, like if fractures after the age of 50, loss of more than 4 cm of height, low body weight, hypogonadism, hyperthyroidism, COPD, nephrolithiasis, previous bariatric surgery, diabetes mellitus. Drugs that affect bone metabolism, like patient is on glucocorticoid, tricyclic antidepressant, gonadotropin releasing hormone agonist, and other lifestyle factors like excessive alcohol or smoking. We should also try to calculate the fracture risk calculators as like fracture risk assessment tool, routine laboratory workup in form of CBC, routine blood investigations, KFT, liver function test. Also see calcium phosphate and always see albumin adjusted calcium rather. 25 hydroxyvitamin D, ALP, and 24-hour urine calcium and creatinine. Morning testosterone and SHBG, that is sex hormone binding globulin levels, are even checked up even up to like 3 times in men with osteoporosis who have hypogonadism signs like testicular atrophy or symptoms of low libido. Further testing might depend upon the history examination or routine lab tests include tests for thyroid disease, hyperparathyroidism, Cushing's syndrome, systemic mastocytosis, and that is done by measuring the tryptase levels. Uh, Try to rule out the malabsorption syndromes, celiac disease. Management should always be individualized. Consider age and ethnicity, comorbidities, severity of osteoporosis, BMD, fracture history, and recent history of fractures. Patient education improves the quality of life, adherence to treatment, and helps the patient implement changes to daily living activities that may decrease the risk of fractures. Uh, Smoking cessation, moderate alcohol intake, and increased physical activity should be promoted. In addition, the diet should be healthy and sufficient to avoid the weight loss if the patient is non-obese. And the recommended daily intake of calcium should also be like 800 to 1200 milligram. So men more than 70 years, DEXA screening always recommended. Treatment recommended if recent history of fragility fracture, if T-score is less than minus 2.5. Glucocortic patient is on glucocorticoid therapy or androgen deprivation therapy. Uh, Also, these should be supported by the FRAX scoring. 50 to 69 DEXA screening recommended if presence of incident fragility fracture, one or more major risk factors. Treatment is recommended if history of fragility fracture T-score is less than minus 2.5. Glucocorticoid therapy or androgen deprivation therapy is there. It should be supported by DEXA score. Less than 50 only recommended if presence of incident fragility fracture, one or more major risk factors. Treatment is recommended if recent fragility fracture or Z score is less than minus 2. So, as we have discussed, that what are the major risk factors if we see in the age group of 50 to 69 years or like in age of less than 50 years. So major risk factors include the delayed puberty, hypogonadism, hyperparathyroidism, hyperthyroidism, COPD, glucocorticoids, androgen deprivation therapy, alcohol abuse, smoking, or other causes of secondary osteoporosis. How to calculate the fracture score? So the major fracture risk, if more than 20%, or hip fracture is more than 3%. So in Indian scenario, that major fracture, if more than 10%, or hip fracture more than 3.5%, should be taken into account. So there is a slight difference between this criteria for that when to treat the patient in Indian scenario if major fracture risk is more than 10%, or hip fracture risk is more than 3.5% as per fracture score calculation. And the currently approved drugs for the treatment of osteoporosis in men are the bisphosphonates, alendronate, and risodronate. These are the oral drugs, and other drugs, ibandronate is also approved. The most important is the zoledronic acid, which is given as 5 mg every year, and others are denosumab. It is a antibody against the rank ligand, and that is given subcutaneous injection 60 mg every 6 months. Other anabolic agent is teriparatide, which is given in form of subcutaneous injection 20 microgram per day. These are fewer studies which does show the change from baseline BMD in case of lumbar spine at the end of 12 months, and this supports the use of denosumab. As we have already discussed, that there was a significant increase in BMD at all skeletal sites assessed after 1 year of denosumab therapy in men with low BMD. This is supporting the role of zoledronic acid in men with osteoporosis, and it does show that even in men with those with the low serum levels of total testosterone, it should be used as a primary mode of therapy for treatment of male men with osteoporosis. And it also significantly reduced the risk of vertebral fractures among men with osteoporosis. This study published in this article supports the role of teriparatide, which resulted in increase in bone mineral density. It is a potentially useful therapy for osteoporosis. This study, phase 3 randomized bridge study, did so evaluate the efficacy and safety of romosozumab in treating the men with osteoporosis for 12 months. And this study concluded that treatment for 12 months with romosozumab increased the spine and hip BMD compared with placebo and was well tolerated in men with osteoporosis. So we can conclude that 1/4 of fractures in patients over 50 years occur in men. Men with T score even between -2.5 to -1 should be assessed by fracture or similar tools to determine the fracture risk. At least half of men with osteoporosis have secondary causes of bone loss, and identification and treatment of these causes may help prevent further bone loss and possibly improve the bone density. Thank you.